Hello, my name is Maria Periselda. I'm professor of neurosurgery at Mayo Clinic in Rochester, and I'm going to talk about surgical anatomy of the open and endonasal approaches to the anterior cranial fossa and discuss a few clinical cases. To start with the classical anatomy, we have here the skull, where we can see the anterior cranial fossa that is bounded posteriorly by the lesser wing of the sphenoid, then ends in the anterior clinoid process. And then we can see the roof of the orbit bilaterally, followed in midline by the cribriform plate and the crista galli. Posteriorly, we can see a flat area called the planum, and then the limbus of the sphenoid, and in between both optic canals, the prechiasmatic sulcus that ends in the tuberculum, and then posterior to the tuberculum, we're going to see the sella turcica for the pituitary gland. Here we see how the frontal bone articulates with the ethmoid bone, and this is the ethmoid notch with the cribriform plate, the crista galli, that are part of the ethmoid, and the ethmoid labyrinth, and this is the middle turbinate posteriorly. So the ethmoid labyrinth is covered superiorly by the frontal bone. If we look at how the skull base is built posteriorly, we can see the frontal bone articulated with the ethmoid. Here's again the cribriform plate and the crista galli, and it articulates posteriorly with the sphenoid bone. An inferior view of the anterior cranial base from the endonasal point of view shows the superior aspect of both orbits, and this is the frontal bone, and here articulating with the ethmoid, this is the perpendicular plate of the ethmoid, that is a superior aspect of the septum of the nose, and here the labyrinth and the middle turbinate. The superior and middle turbinate, and also in case there is a supreme turbinate, are part of the ethmoid bone, whereas the inferior turbinate is an independent bone. Here we see the sphenoid bone articulating posteriorly with the frontal and the ethmoid. Here we see the sphenoid bone with the lesser wing and the greater wing, and the superior orbital fissure in between. This is the anterior clinoid process, and we see very well the limbus of the sphenoid, the prechiasmatic sulcus, and the tuberculum. Here posteriorly, the dorsum of the sphenoid, that is part of the upper clivus. This picture illustrates the skull base and the relationship of the anterior cranial fossa with the frontal sinus, the ethmoid sinus, the sphenoid sinus, and its medial relationship with the orbit. Now let's talk about the approaches to the anterior cranial fossa, and first talking about the open approaches. When we perform a bicoronal incision with harvest of pericranial flap inferiorly, usually we see the orbital rim superiorly, and we perform a craniotomy that has to be tailored to the pathology, and usually we enter the frontal sinus that has to be cranialized, and when we expose the dura, we want to divide the dura inferiorly, ligating the end or the anterior aspect of the superior sagittal sinus, and then we divide the falx. This is the view when we ligate the superior sagittal sinus inferiorly as close as possible to the crista galli, and we divide the end of the falx, and we can see the anterior cranial fossa, and here in the cribriform plate we see the olfactory bulb and the olfactory tracts bilaterally. If we look posteriorly, we can see the limbus of the sphenoid, and these are the optic nerves. We have the internal carotid arteries, and this is the origin of the ophthalmic artery that is usually medial to the optic nerve. And posteriorly attached to the tuberculum, we can see the diaphragm of the sella, and here we can see the pituitary stalk. We can also have access, this is the ACOM complex, we can have access to the intraventricular space through the lamina terminalis, and this is the third ventricle right here. If we perform a craniotomy going through the sinuses, so towards the sinuses, we can see that if we drill this area, we enter into the ethmoid, and this is the anterior ethmoidal artery, and here the posterior ethmoidal arteries, and those again come from the ophthalmic artery. The important aspect of this is that we need to coagulate and divide them and make sure that they don't retract into the orbit, which can cause an intraorbital hematoma and then blindness of the patient if we don't realize about it. So very important to look at those arteries and make sure we coagulate and divide them so they don't retract into the orbit. This is an anterolateral view of the skull base. Earlier we discussed the anterior skull base, and now a few words about the cavernous sinus. We see here the optic nerve, and this is the area of the optic strut that has been drilled after removing the arterioclinoid process, and we have access to the sphenoid sinus through this area, and also we can see sphenoid sinus medial to the optic canal. If we look at the cavernous sinus anatomy, we can see the carotid medially with the posterior band and the anterior band, and we see the third cranial nerve, the fourth cranial nerve, and V1 on the lateral aspect of the cavernous sinus, and inside the cavernous sinus we see cranial nerve 6. They go towards the orbit through the superior orbital fissure. And if we look at the anterolateral approaches that have both components, and the anterior cranial fossa component axis and the middle cranial fossa, including the cavernous sinus axis, this is the frontotemporal craniotomy, the classic craniotomy, when we can expose also the orbital roof, part of the anterior cranial fossa. On the ipsilateral side, we can see the clinoid process, and here we see a beautiful access to the middle fossa as well, with the superior orbital fissure contents coming from the cavernous sinus. So will be cranial nerve 3, 4, V1, and 6 through the cavernous sinus, and then we can see V2 and V3, and this is GSPN. If we perform an anterior clinoidectomy and optic nerve decompression, we can see here the optic nerve and here the dura of the optic canal, and the anterior clinoid has been removed, and this shows very well the internal carotid artery in the clinoid segment and intracranial segment. And then we can see here the third cranial nerve, and in between them we see the posterior clinoid process. If we perform a transcavernous approach and then we open the cistern of the third nerve, also the cistern of the fourth nerve following the tentorium, and then we drill part of the posterior clinoid and part of the clivus. This is the view that we get of the brainstem. And then that can be also combined, so this is the basilar artery that can be also combined with a Kawase approach, and we have a beautiful access of the brainstem there. This is a view of the pons, and this is the fifth cranial nerve. These are 7th and 8th cranial nerve here posteriorly. So if we look at the anatomy from an endoscopic endonasal point of view, we see here the posterior band and the anterior band of the carotid, and this is in the context of the sphenoid sinus, and it's very important to know that there are different anatomies and very variable depending on pneumatization of the sphenoid sinus, but the important is to realize that we have acellular prominence, carotid artery prominences, optic nerve prominences, tuberculum recess, lateral opticocarotid recesses, and clival recess. So what that means intracranially is that we are going to have, this is the limbus of the sphenoid in the superior aspect between both optic nerve prominences. This is the tuberculum that corresponds to the tuberculum recess and is the attachment of the diaphragm of the sella. And the prechiasmatic sulcus is really in between both optic nerve prominences, and that is the key access to the suprasellar space. So this is a view of the suprasellar space where we can see the optic chias posteriorly, and very nice access through the tuberculum, prechiasmatic sulcus and transplanum approach of the ACA complexes, and this is A2 and the optic canals, optic nerves, and the branches, the chiasmatic branches of the superior hypophyseal arteries. Now let's start describing the endoscopic endonasal transcellular and transcavernous approach. We start by the nasal aspect of the approach, and these are the inferior and the middle turbinate, and this is the septum, so this is the left nasal cavity. We want to go posteriorly just above to the coena, and this is the superior and supreme turbinate, and the ostium of the sphenoid is going to be just medial to that. If we perform a posterior ethmoidectomy, and we open in both sides. So this is performed on the left side and not on the right side, but we really need to perform a posterior ethmoidectomy to open the anterior aspect of the sphenoid widely. So we can see this view that is a view of the transsphenoidal approach, and if we drill all these components, we can see the sella and the carotid arteries. So for a pituitary tumor, usually we just need to expose the sella. For a transcavernous approach, we need to expose lateral, and we may need to expose the carotid arteries, and its extensions really depends on the case. So for the endoscopic endonasal approach to the anterior cranial fossa, we can do it in two ways. One, either being conservative with the approach and preservation of nasal structures, or doing a more extensive approach depending on the pathology. So if we look at the, this is the right nasal cavity, the middle turbinate. So just superior to that, in the Agarnase region, if we open that, we can have access to the frontal sinus. And then we also perform sphenoidotomy in the back as well. So we want to remove the superior aspect of the septum and open both frontal sinuses and join them in what we call a draft 3 of the frontal sinus and perform a superior septectomy. And we can be more or less conservative with this, the middle turbinates, but in any event, what we want to get to is this exposure of the skull base, where we can see that this is the area of the curviform plate, this is the area of the crista galli inferiorly, and we have both anterior ethmoidal arteries and also the posterior ethmoidal arteries. And we really need to, again, be careful during this area. We want to expose, coagulate and divide those ethmoidal arteries so they don't retract into the orbit. And this is a craniotomy that looks like this. And when it's performed, we need to remove this part of the bone. We need to remove the part of the bone of the cribriform plate, and then we have the crista galli here that we have to drill superiorly to detach it. And this is going to be the attachment of the fox, so we want to dissect it and remove it. Then we have to divide the dura all around this area, and then we are left with the part that we have to divide the fox in between both frontal lobes. When we retract the dura inferiorly, we see the divided olfactory tracts here and the last aspect of the dura that has to be divided. And this is the final view after dissection of the anterior cranial fossa endonasally. We have both orbits laterally and then the base of the frontal lobes. This is the gyrus rectus, and these are the frontal orbital arteries that are the arteries that we see just on the base of the frontal lobe, and the olfactory bulbs and the olfactory tracts. And we may or may not need to expose in surgery at the same time the optic nerves that are here. This is the ophthalmic artery and the carotid arteries. This is a case of a patient with frontal lobe dysfunction and a large tumor that is consistent with meningioma with edema. So there are a few different approaches that can be performed for this. I elected to do a frontotemporal approach with orbital osteotomy to reach the highest part of that tumor. And please note also the hyperostosis frontalis in both sides that made the surgery a little bit more challenging. The patient did really well after the operation with no neurological deficits, and he discharged uneventfully from the hospital. This is a case in which it was decided to perform an endoscopic endonasal approach, as the patient had anosmia and a tumor that was thought to be quite favorable for endoscopic endonasal approach. This is a surgery in which we performed an opening in the frontal sinus to perform first a draft 3 after opening the sphenoid sinus bilaterally. And here we can see the access to the base of the anterior fossa, and this is the bulk in the tumor. And after The tumor is debulked and dissected. This is the final view after resection of the tumor with collagen graft reconstruction and a nasoseptal flap. This is the postoperative MRI. The patient did really well after surgery. This is the case of another young patient with a growing tumor consistent with a planomeningioma. We elected to perform an endoscopic endonasal approach, and here is drilling the tuberculum and planum. Of note, this was not a well-nomatized sphenoid sinus. This is the cellular type of sphenoid sinus where not all the recesses and the prominences of the sphenoid sinus are readily visible. So there's more drilling than usual. Here is drilling the tuberculum and the prechiasmatic sulcus and removing the bone around the planum. The only structure that is a reliable reference of midline is the rostrum of the sphenoid, not the sphenoid septations that most of the times end in one of the carotid arteries. Here is drilling the prechiasmatic sulcus, and here exposing the superior aspect of the sella, and this is the dura over the pituitary gland. And here again, continuing the drilling, we can see the pituitary gland inferiorly and superiorly the dura of the planum. And after drilling the medial aspect of the optic canal on the right side, I proceeded to open the dura around the tumor. The beauty of this approach is that we see the base of the tumor first, and we are able to devascularize most of the tumor. This was a very fibrous tumor, so ultrasonic aspirator was used to debulk the tumor, and here is dissecting the tumor from the adjacent frontal lobes. And we can see very well the anterior communicating artery complex, A1 and A2 bilaterally. The first branch that we see of the anterior cerebral artery that runs on the base of the frontal lobes related to the gyrus rectus is the frontal orbital or orbitofrontal artery. So we have to assume that it's related to this tumor either in the tumor or around the tumor in the surface. So here we see a branch of the frontal orbital artery that's related to the back of the tumor. So we have to take care of that and dissect and coagulate this little branch of the frontal orbital artery. This is coagulating that PL branch to it. And here we see a nice view of the anterior communicating artery complex. This is lamina terminalis and the optic chiasm. And this is the defect that we have to reconstruct. I usually reconstruct with a button fascial allograft with an inlay and a non-lay graft, followed by a nasoseptal flap with the ENT colleagues. And this is placing the nasoseptal flap and finishing the operation with biological glue. The patient did very well with no new neurological deficits. Most of the material of this talk can be downloaded for free in this supplement of the Skull-Based Journal. And I need to acknowledge the dissections in this talk, most of them from the Roten program at the Mayo Clinic in Rochester, Minnesota. Thank you very much for your attention.